Good afternoon, everyone. My name is Derek Hupp. I'm a third-year resident in internal medicine at the University of Iowa Hospitals and Clinics, and today I am honored to present to you at the 2020 SGIM Midwest Regional Virtual Meeting, our innovation entitled Improving Diabetic Foot Exams in a VA Primary Care Clinic. Our objectives for this talk: we will review the importance of the comprehensive diabetic foot exam in chronic diabetes management. I will present to you the American Diabetes Association standard of care in diabetic foot exam performance. I will describe a quality improvement initiative that led to increased rates of diabetic foot exam performance at our Iowa City VA primary care clinic. And we will review the results of our first PDSA cycle and lessons learned in that process. So, why did we focus on the diabetic foot exam? We knew that in our VA clinic population that there is a high prevalence of diabetes. So, if we were to focus on that problem, we could have a big impact. We focused on the ADA standards of care, which are a collection of important metrics that can be used to guide your diabetes management. We also knew that foot ulceration is associated with high morbidity, is preceded by neuropathy, and can be found early on a comprehensive diabetic foot exam. In our initial data poll, of the 770 diabetic patients who had been seen in our clinic in the past year, only 37% were up to date on a comprehensive diabetic foot exam. 38% were overdue, and 25% had refused, showing that there was a large margin for improvement. So, what is the ADA standard of care? A comprehensive diabetic foot exam is recommended annually for screening for neuropathy. You will inspect the skin, evaluate for foot deformities, perform 2 sensory tests, including a 10-gram monofilament and 1 other neurological assessment, and identify evidence of vascular disease. If there are any positive findings, you'll evaluate for reversible causes, teach the patient appropriate foot care, consider referral to podiatry, and ordering diabetic shoes. And here on the right are an example of some of the tools that are important in a comprehensive diabetic foot exam. In our initial literature review, we found that simple information about foot care can lead to decreased morbidity, hospitalization, and amputations. A protocol put together to screen and treat at-risk feet also can lead to decreased hospitalizations and amputations. And custom orthotics and shoes, which can come from an abnormal foot exam, can lead to a 3-fold decrease in ulcer incidence at 12 months. And this is not just a problem in our own resident continuity clinic. An urban diabetes specialty clinic in Seattle, Washington showed that only 16% of their patients had a comprehensive diabetic foot exam documented per the ADA. And a Midwest clinic QI project showed that close to half of their diabetic patients lacked at least one component of the comprehensive diabetic foot exam on initial chart audit. So, our smart aim was to increase the percentage of diabetic patients in our VA primary care clinic with a completed comprehensive diabetic foot exam to greater than 50% by June 30th, 2020. The setting of our project was the Iowa City, Iowa VA Resident Primary Care Clinic. 8 internal medicine residents participated with assistance from 2 of our faculty mentors, our staff LPNs who were found to be instrumental in the foot exam process, and our podiatry colleagues who provided assistance and guidance. So, our first PDSA cycle involved task sharing and reminder completion. In the previous process, LPNs were the most instrumental group in our clinic in performing diabetic foot exams. They would receive an electronic reminder for a diabetic foot exam, perform the entire exam, and document it by resolving the reminder in the medical record. After discussion with our LPN colleagues and other stakeholders in the process, we created a new process where residents would turn on the reminder as well. LPNs would remove the shoes of patients needing a comprehensive diabetic foot exam as a cue to the residents, and then residents would perform the exam and resolve the reminder, ensuring that every visit where a foot exam was due, it would be performed and the reminder would be resolved right there. In our first PDSA cycle, which was over the course of 1 week, we saw 40 different diabetic patients. 20 of them were due for a comprehensive diabetic foot exam. 55% of those 20 patients received a comprehensive diabetic foot exam with reminder resolution during their visit. 11 of those 20 had the exam performed and reminder resolved. One, in light blue, was noted that his outside physician had recently examined him. One, in purple, the exam was performed without reminder resolution. And in the final 7, 3 were noted by our LPN colleagues as having been done previously with reminder resolution at that time, saying that the exam was normal, and then pushing back the reminder. And 4 patients refused. And I think it's important to note here that with the 20 patients who were already up to date and the 11 that were completed, this was approximately 80% of the patients that were seen during that week being found to be up to date with a comprehensive diabetic foot exam at the end of the week. There were several lessons that we learned during this 1-week PDSA cycle that we can apply to the future. And they were focused on knowledge gaps, procedure issues, and timing constraints. In the area of knowledge gaps, we realized that we don't know exactly if we're performing the comprehensive diabetic foot exam correctly. Both we as residents and our LPN colleagues felt this way. This was mainly in the area of gauging neuropathy and using the monofilament correctly. We had assumed that if a patient were being seen by podiatry, that all of those visits included comprehensive diabetic foot care. This would mean that if a patient were being seen for nail care, we would assume that they had had a foot exam and not performed the exam. However, we realized that this is not always the case and could lead to an area of improvement where we would always perform the exam. Procedure issues were also seen during this process. Our nursing colleagues would ask the patients when their last comprehensive diabetic foot exams were, even if the reminder said the foot exam were due, and this negated the benefit of the reminder. Many times the patient would say that his last exam was several months ago, even if they didn't have a visit at that time. This could then lead to the exam being pushed out for even longer than a year. Also, the reminder, which is the VA's chief way of cataloging these exams, is not utilized in other clinics. Timing constraints were another issue we found. Our nursing colleagues have a large charting burden, and there is incentive to rely on that patient memory for the last exam when they are running behind in clinic. So, the next steps of this process, we will expand the task sharing process to all internal medicine residents at the Iowa City VA. We initially sent out an email to each group of residents. However, in the current COVID-19 pandemic, when in-person outpatient visits were down, it is hard to know if they've been able to turn on a reminder. So we will consider in the coming weeks in-person meetings with each group with data presentation to show them the benefit of this process. We are also considering a patient survey about why the patients refuse exams to better help them get that exam completed at their clinic visit. Preliminary data from these perspectives is pending. Here are the references that we used in the making of this presentation. And I would just like to thank several different people who helped us with this project, including our pharmacy colleagues, our RN colleagues, the VA podiatry department, our LPN staff, and our 2 important staff mentors, Dr. Brendan Boyle and Dr. Krista Johnson. And so I would like to say thank you for listening to this presentation, and I'll open it up to any questions. Thank you.